We might get started. Hi, everyone, and thanks for coming. My name is Anne-Marie Martin, and I'm the Choosing Wisely Health Services Lead. I'd like to begin today's session by acknowledging the traditional owners of the land that we're on today. Pay my respect to the elders past, present, and emerging. So welcome everyone to the March Choosing Wisely webinar, and it's my pleasure to welcome Dr. Paul Bunting from Eastern Health, who will be talking to us about the NUTS program. So I hand over to you, Paul.
Great, thanks very much, Anne-Marie. I'm going to start sharing my screen. Right, well, hello everybody, and thanks Anne-Marie again for inviting me to talk. I've titled this talk, Still Going Nuts at Eastern Health, because I realised when I was sort of putting together, it's now 10 years since we started our NUTS or No Unnecessary Test program, and probably a good opportunity to sort of review some of the things that we've learnt during that journey, what we're still doing, what we've sort of discarded, what works well, what doesn't, what's hard work and what's an easy gain. And just give a little bit of a talk about our journey that we're still very much on. For those of you who are thinking, what's he talking about? This is a Choosing Wisely talk, not a NUT talk. NUT stands for No Unnecessary Tests. And it was a little acronym we came up with 10 years ago when we decided to focus specifically on the test reduction element of this. Now, obviously, reducing low-value care is a much bigger thing than reducing medical tests, but this particular aspect of our program is the bit that's focused on reducing unnecessary medical tests. And the basic principles are fairly simple. Patients shouldn't receive investigations that won't benefit clinical decision-making, i.e. they should just get investigations that are going to help them. So they shouldn't be done if they're unnecessary, where there's evidence that show that they don't help. And this is sort of a hospital-specific thing. We have to be very careful governing our resources. So in some situations, we try and do too much in the hospital or in the emergency department, and where appropriate, we say, well, look, let's see if we can defer things to an ambulatory setting if it suits the patient. So a little bit of a summary. Not sure if for you guys some of this text is obscured by the window, but I'll move it down there. So in 2012, we started really with a urine flow chart. That was the first thing we did, just to try and guide clinicians on when it was appropriate to test urine in the ED. It's not just a standard thing that should be done on every single patient who turns up. There should be a reason for testing it. So that was the first thing we did. We started getting a little bit of formal incorporation into the hospital system the following year with a steering group and subcommittee, and the following year came up with some consensus guidelines. But nothing much really happened over those few years because there was no money allocated to this and there was no person allocated. It's quite easy to get people to come along to a meeting once a month and discuss things, but to actually do some stuff takes human resources. So there was a lot of interest, but not a lot happening until 2015, when I personally was able to take a 6-month sabbatical to really focus on this. And that was the first opportunity for Eastern Health for us to have essentially a full-time clinician allocated to this for 6 months, which allowed me to actually start analysing data and come up with some solid interventions. And the first things I did during that period was to design a pathway to guide pulmonary embolism diagnosis in the ED, and to embed some electronic decision support into our EMR at the time, focusing on 5 of the 10 most commonly ordered tests in the emergency department. We were lucky to win the Victorian Public Healthcare Award for Quality and Safety the following year. And then that led on to a funded Better Care Victoria, now Safer Care Victoria, but Better Care Victoria back then, project with a project officer and funding for clinicians from all different specialties to sort of focus on different things that they wanted to do. And this was really our big implementation stage. We expanded from the work I'd done at Box Hill to the other 2 Eastern Health emergency departments. We expanded into ICU, general medicine, and Choosing Wisely sort of came on board in Australia around the same period. I might be a year off here. It might have been 2016. I can't remember. But around about then, we also tried to align very much with what Choosing Wisely was starting to do in the hospital setting. So we worked very hard for 12, 18 months to incorporate a lot of things. But as with all things, the funding ran out and the emphasis had to be on sustainability. And I realised that a lot of the things we did we sort of did with a big bang, but it's really hard to continue to reach out to nursing staff and medical staff who are rotating through the various departments of the hospital every 3 months. And it's really exhausting because you're just having to do the same thing again and again and again. So some simplification was required. And along with the simplification, to try and come up with some simple sustainability things, also started looking at things that maybe were going to have a bigger impact. It was very easy to focus on pathology test ordering, and it's very low-hanging fruit. We order a huge number of tests, but from a patient aspect, it's important, but it's perhaps not as important as some of the bigger ticket items like CT scans that have radiation and real implications from having a false positive finding. So there's a little bit of a pivot here to focus a bit more on some of these high stakes tests rather than the low hanging fruit. And in particular, pulmonary embolism, CT scanning of heads and necks, CT scannings of abdomens, and imaging of fracturing, fractures, which often led to CT scans. And we came up with some paper-based pathways for those different areas. We did continue on with a very simplified pathology testing matrix that we encourage our junior medical staff and our nursing staff to use when they're ordering blood tests. We continued a lot of teaching, and this continues. I've said ad hoc teaching because it relies on me having availability and trying to embed that into various programs. So I can't do that all the time. But there's regular medical teaching, medical student, junior medical staff, and senior medical staff, and grand rounds and that sort of thing. We also have a morning huddle every morning, and most of the time there'll be one slide on that huddle that's just got some reminder about one of the NUTS messages. That early focus was very broad, and we got some big results from it. We saw sort of 40-50% reduction in all those blood tests and the imaging for PE in the ED. We saw smaller reductions in general medicine, but we focused there on tests that were just being done on a daily basis. And in ICU, we dropped the sort of daily routine chest X-rays by a quarter, just by making a simple clinical guideline there. But what's probably more important is, did we sustain any of this? And these graphs sort of tell the picture here. We've sort of sustained it, but maybe we're losing that battle. I don't know. On the left is a sort of a combined graph that shows 5 common blood tests sort of all packed in together and then adjusted for patient presentations in the ED. And you can see first 18 months of this program, big reductions. In the last couple of years, a slow creep up, still a long way under where we were at the start of all this, but there is a slow erosion of what we've done. Note that I only go to sort of mid to late 2019, and I'll talk about that in a second. Medical imaging, we started later, sort of in late 2017, I think it was. And you can see that we've reduced imaging there, but not by huge amounts, maybe a 20% reduction in the imaging on the 4 things we're focused on. But then COVID came along, and it's really, really difficult to know what's happening at the moment. The last 2 years is really a big hole in our data, and I suspect this is the same everywhere, certainly everywhere on the East Coast, where we've had lots and lots of effects on our hospital admissions from COVID. Of course, the first thing we saw was a massive reduction in testing because not many people were coming into our emergency departments. But then when you adjust that for patients, you saw an increase in testing because the people who were coming tended to be a little bit sicker. And the people who were avoiding ED were people who may not have had testing in the first place. And then for certain areas like pulmonary embolism, testing went right up, partly because people were coming in with respiratory symptoms and partly because of scares with AstraZeneca vaccine and that sort of thing. So I really struggled to analyse the COVID data, which is why I've not shown any. because I'm not sure what it means, and I'm not sure when things will settle down. But it's going to be difficult to know what longitudinal data looks like, because there's this 2 years from sort of early 2020 till now where things are still not quite normal. So the things we've done are varied, and like I said at the start, some have been very successful and some haven't. For the first 4 years, we, like I said, went off for a bit of a bang. We had some funding, we had a lot of enthusiasm. We designed a huge number of teaching packages, I guess, to roll out, and tried to make them as easy as possible for other people who weren't part of the NUTS team to access and sort of, incorporate into their teaching with varied success. We tried to incorporate game theory as much as possible. It's hard to incorporate game theory in a hospital setting, but we had a poster competition where people, came up with memes and so on, and there was quite a bit of enthusiasm. It's funny looking back at these now, and you realise how dated things get. So at the time, Game of Thrones was all the rage, and people had all these Game of Thrones things, and Donald Trump was all in the news, so there were lots of memes about Donald Trump. And I look at them now and go, well, they're not very relevant anymore, which sort of raises one of the challenges with this. Sustainability, it's not a set and forget thing. If you want to have posters in your department, you've got to update them every year, else they sort of lose their impact and they look a bit old. We did a lot of audit and feedback, which I think was very successful. And I would highlight this as something that I would recommend for anyone who's got resources for CT scanning. We actually, I had nursing staff every week who could look at CT scans that were ordered, see whether they met our guidelines, and when they didn't, send gentle reminders to staff saying, or not even reminders, sort of inquiries and flags saying, I notice you ordered this CT scan. I'm not telling you can't do it. I'm just curious to know why you did it, because it's not sort of aligning with our guidelines. And that worked fairly well. Sometimes staff would get a bit upset and offended by it and say, well, who are you to question me? But most of the time it served as a little flag to go, okay, well, this is being watched and we do have a process here. And I think it did help, but it's resource intensive and you can't keep it up forever unless you've got ongoing funding. So for the last couple of years, we've moved more towards, like I said, ad hoc teaching, regular staff updates, paper pathways, and I've put, you can't read them, but that's 4 of our paper pathways that we use in our department. And the uptake with them is pretty good. Clinicians are pretty aware of them, and they do use them most of the time, not so much the yellow abdominal pain one, but definitely the other 3. Not all the time, but most of the time. There's a lot of protocol variation, but violation, I should say, but even when that happens, clinicians are still using these as worksheets to sort of decide, whether they're going to follow it or not. And I should sort of just mention briefly here that I'm skeptical of electronic decision support. It seems silly that we're, after 10 years, still using paper pathways, and it seems old-fashioned, but a paper pathway can be picked up by a junior doctor. They can carry it to the senior doctor. They can sit down together. They can work through it. And come to a conclusion. It's difficult to replicate that on an electronic system. You can build these pathways into an electronic system very easily, but typically clinicians make a decision and then they sit down at the computer to do the order. And if they're faced with a decision support at that point, it's a little bit too late because they've already made their mind up. And then they'll just fudge it to try and get through because they don't want to change their mind once it's made up. So trying to incorporate the decision support into the time of the decision-making is a challenge, and paper pathways work well for that. It's a little bit more tricky to do it in an EMR. And yet, despite that, an EMR is what ultimately you want to incorporate it into. I'm going to move one of these pathways to our EMR in the next 6 months and just watch it closely and see what happens. But it's tricky. It's not as straightforward as it may appear. The other thing on this slide here is our pathology matrix up on the top right, and that's a guide for our nurses and for our medical staff as to what blood tests we think It's okay to order without talking to someone senior for common ED clinicians. The issue is that people don't use it very well. We've got chest pain, likely AMI there, saying, yeah, get an FPEU and troponin. And yet I can tell you right now that any chest pain coming in the door, people don't take that extra step and say, do I really think this might be an AMI? I know you're hit with a basketball on your chest and you've got a bruise there, but I'm still going to get a troponin. There's a lot of thought process that's often taking place in the busy front of house environment, and really trying to encourage people to think a bit more before they sort of blindly order these tests. The other thing we've done is try and integrate some of these things into our official Eastern Health clinical practice guidelines, because it gets a bit more legitimacy once I can do that. And then publishing research outcomes. I sort of realised that the first 3 or 4 years of stuff that we did is invisible to the rest of the world unless it's published. And I would encourage anyone in this space to look and incorporate formal research methodology and have publishing outcomes high on your list early on, because although it may not seem like something that's all that important when you're just trying to change clinicians' behaviour locally, it doesn't give you the same legitimacy until you can actually do that. And here's an example of some of the things we're working on or published. Our PE pathway was published in 2016, I think, showing a 40% reduction in imaging. It's a bit less than that with ongoing sustainability, but that's what we saw when we first brought it in. We've got a paper under review at the moment, applying the Canadian CT brain rule to all of our patients, and in particular, this one focuses on patients from residential aged care facility. There's a common misconception that these Canadian rules can't be used on elderly patients, and they can. Just need to incorporate some minimum inclusion criteria. And we found that we could safely reduce imaging by 20%. And each one of those patients not getting imaging, in theory, not all of them, but most of them not getting imaging, could potentially be handled in the residential aged care facility and not actually sent to ED in the first place, which is probably the next step in involving that. We're currently having a look at what effect our Canadian spine rule minimum inclusion criteria are having on imaging. And a big audit that one of my nurses has done from us, thesis, showed that even though we've pushed this rule very hard, 17% of the scans that are being done in our ED are unnecessary as per our guidelines, and every single one of the unnecessary ones when we've ordered it has had a negative result. Likewise, we found that troponin ordering in the absence of chest pain was really, really common, and it quite often comes back elevated, resulting in waiting around for a second troponin and so on. But of 372 patients who had troponins ordered with no chest pain, we only found one where it contributed to their ongoing management in a meaningful way, and that patient had obvious ACS changes on their ECG and other things going on. So you could argue that the troponin really didn't do a great deal on its own there anyway. And from here, I think for us, as I said before, an increased emphasis on researching outcomes rather than just sort of implementing things locally. We're doing some work looking at using clinical nudges. I've got a PhD student who's doing that, just trying to work out how you can subtly influence clinicians in positive ways when they are interacting with the EMR. As I said, in exploring how we might integrate our pathways into our EMR. And ultimately, my goal is to incorporate our work into the work being done elsewhere and actually end up with some larger multi-site studies and some big sharing of data and outcomes, and actually make this more of a national thing rather than the little pockets of research that are being done at the moment. So I guess the lessons we've learnt, need a simplified model for sustainability. You can be as fancy as you want when you implement something, but it's pretty hard to keep that up long term. The COM-B model by Susan Mitchie is a nice idea. It's sort of a simplified version of the 15-step behaviour wheel that she's also published, and really focusing on making sure that clinicians have the capability to do what you want, that they're motivated and they have the opportunity. And the various interventions and things that you bring in should sort of link in with those three key themes. You need to have local champions, ideally more than one. You need to publish outcomes to give them legitimacy. Need to share data. It's very difficult for me to say, well, how does our ordering compare with hospital A down the road or hospital B down the road? And even when you do sort of get some local data, often the parameters are a bit different, and it's difficult directly to compare it. I often rely on my registrars who rotate to the different hospitals to say, I ask them, look, what's the testing like there? What are they doing? What are they not doing? And trying to get feedback that way. The feedback I get is that we are focusing on this at Eastern Health more than many of the surrounding hospitals, and they are often a little shocked by the ordering that's taking place in the other hospitals without a lot of thought. You need to be patient. This is something I struggle with. It's a constant, it feels like a constant battle being a local champion year after year after year, and having a constant tide of new doctors and barriers and so on. And you need to often just take a breath and realise that you can't come across as a raving lunatic. You've got to just sort of back down a little bit. Look, change is obviously much easier if it's happening everywhere. If your organisation is not just one little pocket of activity, but rather the part of a bigger picture that's consistent across every hospital, it's way easier to do it. That's it. Nice quick talk. I wanted to leave a little bit of time for talking. I might start by answering the two comments or questions that have been put up. So there's a comment there about managing investigation for nursing home patients using telehealth. And this is something that, yes, I think there is a lot of opportunity for managing nursing home patients, or some subsets, very carefully chosen subsets of nursing home patient conditions, either via telehealth or via local GP visits or in-reach visits or whatever. But I think when we can avoid unnecessary ambulance trips to hospital, there's a huge gain for the patient. There's a question about, audit time. Yes, it's very time consuming. And I sort of touched on that. I was lucky to have funded nurses to do discrete audits for me, and then I just supervise them. And I often have medical students. We in Victoria have, at Eastern Health, we're linked in with Monash University, and the university students have scholarly intensive projects where they rotate through for 6 weeks, and I'll often get one of them involved in a discrete audit. Obviously, that's not an ongoing thing I can do, but yes, I often rely on nursing staff and junior medical staff because I haven't got the time to actually do the audit. I can analyse the data from the audit, but I can't really do it. You can automate audits to some degree, just using sort of basic data, but it's actually very difficult to audit CT scan results, for example, because they're reported in free text. And one of these days we'll have fancy machine learning algorithms that can just scan through and look for sentence structures and so on, but we don't have that yet. So to try and work out what percentage of our CT brains have a bleed on them means reading through them one after the other to say, did it have a bleed? Was it normal? Yes, no. It's actually really difficult.
There was just one question from Chris Leong as well.
Yeah, look, none at the moment, Chris. I'm our research director and I am passionate about this, so I incorporate a lot of this into my portfolio, and I have one EFT of research assistant support, but NUTS is now one of, I think 30 projects I've got running as part of that. And as I said, I have the scholarly intensive students who I often will give NUTS type projects. They make lovely little things for them to present at conferences or even publish. The troponin paper was a research student I had. Another piece of research we published, which I didn't mention, was looking at whether a decision support rule from Italy on when to scan CT, when to perform CT brains in the absence of trauma could be safely done in the ED. And I had a medical student do all that work. We found that his algorithm didn't work, and it was a negative study. We said, well, it actually didn't work. It's not a safe rule in our environment. It would have missed too many important things. But yeah, that was another medical student publication that came out of this. So the medical students are a really good resource because these are nice discrete projects. They get something tangible they can put on their reference, on their CV out of it, and they're the future doctors, so they get enthused by it, and then they take that forward. My medical student who did the troponin work is now a PBT physician trainee about to sit her exams, and she's quite passionate about this stuff. So, that's 3-4 years later. That's something she's carried with her, and I think these students and young doctors and nurses are our future. And I say nurses there not just to add them in. I've had enormous support from the nursing staff, and the nursing staff can put pressure on doctors. With cervical spine imaging, the nursing staff have been great at saying, hang on a second, why have you left that collar on? Why are you imaging this? Why don't we use this pathway to clear that patient and get them out of that really uncomfortable collar? So, yes, the junior staff can be absolutely fantastic.
There's just a question from Suzanne Childs in the Q&A. Yeah, what was your level of consultation between inpatient and ED teams on agreement on minimal testing to assist disposition decision?
So early on in our funded period of this, I had 3 physicians who were part of my team, and they had their own areas that they focused on for inpatient testing, but they also provided me with insight as far as what they felt was reasonable in the ED. My experience has been that I've had excellent buy-in from senior clinicians throughout our organisation. But unfortunately, senior clinicians don't actually make the frontline decisions. They're made by fairly junior clinicians who are usually registrars and usually very scared because they're doing this job for the first time and they're really scared of missing things. And buy-in from them is not very good. And this is a bit of a gap. It's fine for me to have a clinician say, no, this, a great example is our head of surgery saying, no, if a patient's clinically got appendicitis, just send them up. They don't need a CT scan. But then the unaccredited surgical registrars who actually do the admission, they freak out with that and they want to get a CT scan. So yes, it is an issue. It's easy to get buy-in from senior clinicians, hard to get buy-in from junior clinicians, and at the end of the day, hospitals are run by junior clinicians. So it is a challenge.
I'll just take that last question from Robin in the chat because Paul has a plane to catch.
Yeah, look, choosing wisely gives this stuff legitimacy, a bit like publishing does. Once again, you're not just a raving local lunatic with a funny little acronym and picture that you've had your student draw up. You're actually part of a national organisation with professional letterheads and professional resources, and it's incredibly important because you can say, well, this is what Choosing Wisely is doing. This aligns with Choosing Wisely. This is actually a Choosing Wisely resource. Look, here's 5 questions that Choosing Wisely have designed for patients. And it is very, very powerful. That I think some of my doctors would call me a raving lunatic. I try not to be all the time, but I just can't help myself sometimes.
I agree with Susan there. We do need more raving lunatics like you, Paul. So thank you. So thank you so much for your presentation and for the update on sustainability, which is the theme for our national meeting coming up on the 3rd of May. And we'll have a safe flight, and thanks everyone for coming.
Thank you so much for the opportunity to talk.